Thank you so much for listening to the latest episode of Taking Charge of My Cancer podcast. If you have not already, feel free to share this with more people so they can benefit from this information. If you would like to connect with me, see the information on the podcast description. See you later. The information provided on this podcast for educational purposes only and is no intent nor should be used as a substitute for medical advice. Consult a licensed qualified medical physician for any issues concerning your health.
And it's kind of like a lifelong condition. Like you're always going to be having to maintain or like hold on to the bone density you have. You can improve bone density some. And yes, there are people who could be like on the cusp of just barely, having osteoporosis and they don't need to gain so much bone density to flip back into an osteopenic state. But it's not really like, did your status change? That's not the issue. It's just that you've had this progression to loss of bone and you're trying to like build and maintain it. And that's always going to be something that you need to, it's not like you can just stop thinking about it or working on it. And it may gradually decline over time. And bone density isn't everything, but it is certainly an important part of the definition of osteoporosis and a factor in fracture risk. So I think it's important to think of your bone density as something that can be improved.
Welcome back to Taking Charge of My Cancer, the podcast where we empower patient survivors, caregivers, and healthcare professionals with the knowledge and tools to live stronger through every stage of the cancer journey. Today's episode explores an often overlooked aspect of survivorship, the vital connection between musculoskeletal health, women's health, and cancer recovery. I'm thrilled to welcome Dr. Wittstein, an orthopedic surgeon who goes far beyond the operating room. With a special interest in women's musculoskeletal health, Dr. Wittstein collaborates closely with women's health specialists to better understand how conditions such as menopause, osteoporosis, arthritis, adhesive capsulitis, and bone health can impact women through their life, including those navigating cancer treatments and survivorship. So Dr. Wittstein is an associate professor of orthopedic surgery at Duke University Medical School. She studied nutritional science at Cornell University as an undergrad, where she was a collegiate gymnast. She completed her medical degree at East Carolina University, followed by her orthopedic surgery resident at Duke's in 2009. She subsequently completed a fellowship in shoulder and sports medicine at Duke in 2010. Her research includes disorders of the shoulder, knee, and elbow, rotator cuff repair outcomes, biceps tendon disorders, and patellofemoral instability, ACL injuries, including mechanism of injury as post-traumatic arthritis and meniscus healing. She also collaborates extensively with Duke's Women's Health on the study of the intersection of musculoskeletal health and menopause. And she's a co-investigator of 3 NHI grants addressing post-traumatic arthritis and chondral resilience after ACL and meniscus surgery, as well as the risk of ACL, including fatigue, anatomy, and sex hormones. As a mother of 5, she also found time to author her first book, The Complete Bone and Joint Health Plan, which was released last year, May 6, 2025. And then she joined in the same year the Milkins Institute Women's Health Network, chaired by Dr. Jill Biden. In 2026, she was appointed for the Scientific Medical Advisor Committee to the Bone Health and Osteoporosis Foundation. And I can continue on and on, but we need to start to jump into our conversation. So thank you so much for being here with us today.
Mm-hmm.
So can you tell us about your journey into orthopedic surgery and then your interest in women's musculoskeletal health?
Yeah. Like many orthopedic surgeons, I think my introduction to the field was through the field of sports medicine as an athlete. And I think a lot of people get exposed to the field in that way. And then, so I was a gymnast in college. And then ultimately, once I went through my orthopedic training, I decided I wanted to be a sports medicine specialist. But I do take care of a lot of female athletes. And of course, women are athletes across the whole health span. So there are, young, pre-adolescent, adolescent, high school, college age athletes. And then, of course, people competing recreationally and competitively in their 20s, 30s, and 40s and beyond as masters athletes. And there is a lot that specifically affects the female athlete at various phases of life. And then on top of what affects athletes, of course, there are things that affect women and their musculoskeletal system. And a lot of them these inflection points and changes are related to menopausal changes, and many of the musculoskeletal effects of menopause actually are essentially parallel to some of the effects of some of the management of breast cancer, like aromatase inhibitors and things like that, which can essentially put women into a menopausal state. So all these things kind of connect in various ways.
Absolutely. And I was very surprised, and I think I was listening to Dr. Mary Claire at one point talking about frozen shoulder and menopause, which I was like, oh my God, like that was the first time I heard about it about like a year and a half or something, and how I'm just really paying even more attention in our breast cancer patients, when they come and they start complaining about, some inflammation is
Stiff, painful shoulders, yeah.
exactly, painful shoulders, and then become just more like an adhesive capsulitis kind of situation. So why do you think frozen shoulders seems to be more common in women during midlife? Why is that?
Yeah, well, I would say the first clue I had into this topic and why I started studying it and thinking about it was really my patients who happen to have had breast cancer. And at first I thought maybe their stiff shoulders were related to, surgical interventions, mastectomies, reconstructions, where they've kind of had fear of movement of the upper extremity, or maybe even lymphedema or radiation. But then I started realizing, even people who didn't have all those components, but who were on, aromatase inhibitors, for example, were of course getting a lot of joint pain. And we know that aromatase inhibitors are associated with something called AIMS, aromatase inhibitor musculoskeletal syndrome, which is, about half of people have quite a lot of arthralgia on those medications. And they're basically put into a low estrogen state, or essentially a no estrogen state. And so I started seeing and realizing that a lot of women on these medications were experiencing frozen shoulder. But then, I started thinking about, of course, there are endocrinopathies associated with frozen shoulder, but we see, the most common age and sex to experience frozen shoulder are women between the age of 40 and 60, which of course encompasses most of perimenopause and menopause and postmenopause. And we know estrogen is an anti-inflammatory hormone that affects joints, and certainly women are also more predisposed to arthritis. For example, knee arthritis is much more common in women. So there are, of course, estrogen receptors in the shoulder, and we now know from some basic science studies that estrogen also inhibits the cell type called fibroblasts, which can thicken and inflame the lining of the shoulder joint. So it makes sense that you have this condition that primarily affects women, particularly in the perimenopause and menopausal age range, that there would be some influence of hormonal changes in estrogen. Now, we also will rarely see frozen shoulder in men. Of course, these are men with diabetes. And so there's probably an intersection of endocrine health, metabolic changes, also hormone changes, all kind of potentially adding up in this population. And of course, in perimenopause and menopause, we also see changes in insulin resistance as well, related to changes in estrogen. So I think there are a lot of things at play, but I then did some research on this and continue to study this in terms of the influence of menopause and whether or not women are on hormone therapy and how that may affect the risk of frozen shoulder. And I'm actually presenting on this next week at a national meeting, some of our more recent research sort of confirming some of our earlier suspicions that there is this association of hormone therapy as being associated with less risk of developing frozen shoulder. And then, of course, we see this frozen shoulder as well in women who need to take these medications, which then have these side effects, the aromatase inhibitors. So I think I've learned a lot from my patients with breast cancer, then also my, midlife patients, just sort of asking them, like, what do they have going on? They've got these vasomotor symptoms, but they also have the onset of the shoulder problem. I think they're connected.
Great. And then what would you tell women, like, how do they know they actually start having a frozen shoulder?
Yeah, so I think one of the not mistakes, but one of the things that women often do when they're having pain is wait it out maybe too long, and things can be really bad by the time they seek treatment. And so one of the key critical aspects of frozen shoulder is being treated earlier rather than later, because different treatment options work better when you catch it early. So frozen shoulder can present with basically no trauma, or maybe very minor trauma. Like a very common example someone might give would be like their dog pulling on the leash a little bit or something like that. Or I've even had someone say, I just swatted a fly, a sudden movement. All of a sudden my shoulder was hurting really bad. I just woke up and it was really painful. And so, it's this strange presentation of really severe shoulder pain, and not at first stiffness, but just a lot of pain without much injury. And the pain will be at the extremes of motion. So you may be rotating your arm out the side, and it's okay in here, but when you get to the final range of motion you have at that end range, it can be painful, for example. And then it progresses from this inflamed state to this frozen state. So at some point there starts to be loss of motion. But the confusing thing is at first there will be like painful range of motion, but you haven't lost the range of motion yet. And then it can progress to this loss of range of motion. And then it has to kind of gradually thaw out over time. And so the key is you would like to catch it within a few months of this all starting. Because if we catch it fairly early, you can treat it with a steroid injection into the joint space, kind of reduce the inflammation, sort of block that freezing process. And people can do really well with that. Occasionally, they might need to repeat it, one time. Also really important to pay attention to glucose control at this time if anyone is like pre-diabetic or diabetic. And then I do sometimes refer people, if they're also having vasomotor symptoms, for management of that, which I do think then also has a positive effect on their joints. And so I think the key is listen to yourself. If you have shoulder pain, new onset without trauma, and it's getting worse, and especially if you notice you're like rapidly losing range of motion, like can't reach behind the back, can't fasten a bra, can't tuck a shirt in, or manage a belt loop, that kind of thing. Or if you look down and you just compare your range of motion like side to side, like if you notice a difference that you're losing rotation at the side, which is the first range of motion for people to lose. If you can't wash under your opposite armpit because you just can't reach across your body, that's another example. Things like that, I would go get it checked out by either like an orthopedic surgeon or a primary care sports medicine doctor, someone who might be able to give you an injection if you need it. This is one of the few conditions where I think when a physical therapist sees it and recognizes it, they will send you to the orthopedist pretty early on, because it's one of these conditions, and you may have experienced this, where I always tell people it's one of the few things where not because the physical therapist is doing something wrong, because they're not, it's just the condition. They will recognize that you're getting worse despite, being in physical therapy. It's like the trying to push the motion almost exacerbates it. That's another clue that this might be frozen shoulder. And so many times the people that diagnose frozen shoulder are a physical therapist. So if you're having shoulder pain, there's nothing wrong with seeing a physical therapist first. They might notice that you're losing motion or it's getting exacerbated as you're trying to work through the motion. They may send you to the orthopedic surgeon to try an injection to sort of get past that phase. On the other hand, if you're already frozen and not painful, an injection isn't going to work very well. Physical therapy is going to be your best friend. And sometimes you might ultimately need what's called a lysis of adhesions or manipulation, like a scope and a manipulation of the shoulder to get motion. But we like to avoid that if we can. So that's a long answer, but I think the key is recognizing it early.
Okay.
And going to see someone. You could start with physical therapy, you could see the orthopedic surgeon or primary care sports medicine, but sit on it, because you can get to a different phase where it's harder to get rid of and it lasts longer.
Got you. How about any other orthopedic conditions that you see among breast cancer survivors?
Well, yeah, I mean, depending on the treatment, we talked a little bit about AIMS, the aromatase inhibitor musculoskeletal syndrome, which is this condition that like half of people on these medications have, where they have this increased joint pain, polyarthralgia. Frozen shoulder could be an example of that. But also one of the things to pay attention to, and certainly hopefully your care team is sharing with you if you're on one of these medications, is there can be, this more rapid loss of bone. So a tendency towards developing bone loss, progressing maybe to osteopenia or osteoporosis. So it's important to, have a baseline DEXA scan, know what your bone density is. And then there are, strategies for mitigating the bone loss that can happen with these medications, including treatment with a bisphosphonate. And there's a lot of data that use of bisphosphonates, which are, of course, a type of osteoporosis medication, using this in combination with aromatase inhibitors can prevent bone loss, reduce fracture risk, but also reduce risk of bone metastases, and also reduce mortality.
Oh.
So that's an interesting thing. Yeah, there are some studies looking at different types of osteoporosis medications that can be used to combat the bone loss that occurs with aromatase inhibitors. For example, like Prolia could also be used to prevent bone loss, but it hasn't been shown to have that same other benefit that the bisphosphonate medications have been shown to have in terms of reducing subsequent bone disease, like metastatic disease, or having that effect on mortality rate. So that's, I think, why there's more of this, standard use of bisphosphonates in combination with aromatase inhibitors to prevent bone loss. Musculoskeletal components of that class of medication often used with hormone-sensitive breast cancers, which are the polyarthralgias, the joint pain, and then the risk of bone loss, which can be mitigated. And then some women are on tamoxifen instead of aromatase inhibitors. And one of the interesting things about tamoxifen, there's probably less joint pain, but also if you're a postmenopausal woman and you're on tamoxifen, it can actually have a positive effect on bone, because it's more of a selective estrogen receptor modulator. So that can actually be protective of bone density. So there are little nuances like that that hopefully people have and are receiving from their care teams that are more proactive in
Mhm.
nature, really. Mm-hmm.
So what are your thoughts like in that example that you just put in with tamoxifen and protecting bone health? You think that a patient who already comes in with osteoporosis and then they develop breast cancer and they need to be putting on AIs because being, hormone positive, you think they're going to be better off with tamoxifen to try to protect?
I would never hazard to tell a patient what medication to treat their cancer. I think it's just something to be aware of, or to ask about. It may be that if, maybe in an individual's case, I think there are some people that don't tolerate aromatase inhibitors and then sometimes get switched to tamoxifen. I would never cross that boundary. That's well outside of my area of expertise to kind of make any recommendation about the management of breast cancer. But I do want to say there's another kind of issue that some people get. Of course, lymphedema can be an issue in the upper extremity, especially if anyone has had, node dissection. And so we do see that a lot where people can get, they're in need of lymphedema therapy, but there's also then sometimes this fear of movement of the arm, especially if people have lymphedema. A significant portion of people who are dealing with any lymphedema and breast cancer also have just develop a little bit of fear of movement of the extremity, and that can then maybe also predisposed to frozen shoulder. And so I think lymphedema therapist can be really helpful in that regard as well. So that's sort of a different issue that not everybody has.
Yeah, that's a very good point. Actually, I always tell patients, usually lymphedema is never painful, becomes all when the arm becomes so heavy and then you start to develop some kind of inflammation and then you develop tendinitis or the fear of avoidance, like you say, because they're like, I don't want to move this arm or this arm is just too heavy to move. And that's create more of this kind of like complication with musculoskeletal syndrome. So we always tell patients, you gotta move. The more you move that arm with the right compression, that's gonna pump those muscles. She's gonna help even better for that fluid to start moving in the right path.
Yeah.
What should survivors who should know about protecting their musculoskeletal system? Like you mentioned osteoporosis. So what is the best thing for that?
Yeah, I think it's hard when people are going through treatments that might be making them fatigued and they're having joint pain. I think it's really important to work with physical therapists because one of the things that can help people feel better, even though it may seem counterintuitive, is exercise and strength training. Like continue to participate in resistance training, which will then help your bone density, can also help your joint pain some by keeping the muscles around the joints strong, and of course can contribute to your overall health by contributing to your metabolic health, by maintaining muscle mass, helps you with your cognitive health over time as well. So I think the tricky thing is if people are having joint pain, to work with a physical therapist to find ways that they can still do strength training or find that form of cardiovascular exercise that they can do without aggravating their joints so that they can, stay active and maintain their health otherwise when they're dealing with this. So their endurance, their cardiovascular health, not losing muscle mass again, and that has the added effect of supporting their bone health. And then there's some data that acupuncture can help people who are dealing with this diffuse polyarthralgia, like the AIMS that we talked about. I found that interesting. There was like a recent review article I was just looking at in terms of what interventions can help people with AIMS, and that was one. And then there's another recent article, a small series looking at breast cancer patients who are dealing with AIMS. And found that some like use of a vibration platform was helpful in terms of reducing pain. I don't think it's going to dramatically increase their bone density or anything, but seems to provide some pain interference, which is interesting. And then I read another article recently that was looking at testosterone therapy in women with AIMS, and it's not clear that reduced their discomfort or pain, but it did help them with their vasomotor symptoms a lot, and that can be helpful in terms of improving sleep, and improving sleep can then reduce pain. So and again, I wouldn't hazard to say like who is a candidate for that, but I think these are ideas that are being explored for patients who are dealing with the side effects of the necessary medications and treatments that they're undergoing. So yeah, I think finding ways to maintain your cardiovascular fitness, like those kind of the basics that are good for everyone, but it's definitely a little bit more challenging for people who are dealing with joint pain, and I think that's where physical therapy can be quite helpful.
Yeah. One more thing as well that So as well for your information, aquatic therapy. So aquatic therapy is a great source of that, just because when you're in water, again, it's not the same way bearing, but you actually, the hydrostatic pressure helps a lot with inflammation.
And with the lymphedema as well. Yeah.
So make it feel really well, and then kind of give you the opportunity for more flexibility, mainly if you have.
And I always tell people, who have frozen shoulder, like that is a great way to move your arm is underwater because it eliminates the weight of the arm and people can gently move it underwater. And that doesn't even require a lot of instruction. I mean, you can just be like walking in the water, or you're not swimming, but submerge your arm under the water and you can do gentle range of motion underwater. And that can be a way to do basically like assisted motion with less pain. So that is another benefit of
So
that.
many times when we have patients again with very acute, inflammation that they're really having a hard time doing things on land, we kind of start in aquatic therapy. And again, we do a lot of like modality, like we have a manual therapy, like joint mobilization, things can be done outside on land. So it's a lot of things that as well with an aquatic therapist who actually has a certification and knows. So it's a lot of manual techniques can be in the pool with patients that is really fantastic and can help a lot to kind of get them into that path of like, okay, now we're kind of controlling inflammation, then we can move on into land and working in some other things that they can start tolerating against gravity.
Yeah.
A good option too. What are your biggest misconceptions about osteoporosis that you think patients have?
I think that in general, people don't realize that osteoporosis is preventable or it seems inevitable. I think I don't want to tell people that if you have osteoporosis, I don't like the term. People always ask, can you reverse osteoporosis? And it's kind of like a lifelong condition. Like you're always going to be having to maintain or like hold on to the bone density you have. You can improve bone density some. And yes, there are people who could be like on the cusp of just barely, having osteoporosis and they don't need to gain so much bone density to flip back into an osteopenic state. But it's not really like, did your status change? That's not the issue. It's just that you've had this progression to loss of bone and you're trying to like build and maintain it. And that's always going to be something that you need to, it's not like you can just stop thinking about it or working on it, and it may gradually decline over time. And bone density isn't everything, but it is certainly an important part of the definition of osteoporosis and a factor in fracture risk. So I think it's important to think of your bone density as something that can be improved, but for people who have osteoporosis to kind of consider that a lifelong condition, even if you do kind of flip your status to, osteopenic, for example. So yeah, it's good to know that exercise interventions can improve bone density depending on the intervention, maybe by a few percentage points over a period of time, 6 to 12 months. And sticking with that, you may gradually continue to gain bone density over time. And then certainly, like, not everyone, just because we're aging, not all women are going to get osteoporosis, and it can be prevented in many ways through lifestyle choices, diet, exercise interventions. But there are some things that are just not under our control. They can't control if you get breast cancer and need to be on a aromatase inhibitor. You can't control if you have rheumatoid arthritis and have had to be on, systemic corticosteroids at various periods of time. And so some things are not under our control and some things are. But yeah, I think one of the misconceptions is that osteoporosis is inevitable or that you're just going to continue to lose bone over time, which is not necessarily true.
And again, what are your thoughts on hormone replacement? Again, not the necessarily positive hormone breast cancer patient, but if we have negative or we have somebody who just don't have anything.
Yeah, so it's very well established, of course, that systemic hormone therapy that contains estradiol improves bone density, protects against fractures, reduces risk of developing osteoporosis, and mainly that effect is while you're on the medication. The longer you're on it, the more the protection. When you stop using the hormone therapy, that protective benefit does diminish over time. And the question for like if you're someone who has breast cancer and let's say it's not hormone sensitive, like still again that I wouldn't myself make a recommendation to anyone, certainly globally on any platform, or even any of my patients who have breast cancer. I would certainly defer to them and their oncology team because there's so much nuance to that. But I think the bottom line is it should be a shared decision-making process. They're going to, talk about your history, your risk of recurrence, things like that. One thing that has been very clearly shown is that estrogen has never been shown to use of systemic estrogen hasn't been shown to cause breast cancer. But there are people who have hormone sensitive breast cancers. And obviously, if you are identified as having that, you're going to be put on medication that typically a medication will be used that will block the conversion of testosterone to estrogen or block estrogen. And so you wouldn't be on hormone therapy at that time. The question is, like, there are even people who might consider, like, let's say they've had a mastectomy and they didn't have any metastatic disease, and anyone could have a shared decision-making process with their team and their doctors, like depending on how severe their symptoms are. And, so there are people who have really severe vasomotor symptoms that are not manageable. There's the risk of certainly osteoporosis and things like that, arthralgias. And of course, there are alternative medications for some of these things as well. But I think the bottom line is, I don't know if you follow Dr. Corinne Men, but I love listening to her talk about this as a survivor herself, like just sort of this concept that people should be given information and be allowed to make decisions, not just told no. But it's never going to be in my purview or in my lane to be making recommendations like that or telling people they should be on hormone therapy or not. But there are those benefits for sure.
Right. But I love that you actually know that, right? So it's great to be able to go to your orthopedic surgeon, somebody who sees that part too. It's not just the musculoskeletal, but looking at the whole picture and saying, by the way, this is options for you that you can go and discuss with your gynecologist, like Dr. Men, or with your oncologist or whoever.
Yeah, I mean, a lot of patients ask me that, and I'm just like, I can direct you to people or you have members of your team, but it would be out of my area of expertise to do that really fine sort of risk benefit alternative discussion and management of that. But there are certainly those musculoskeletal benefits of hormone therapy.
Absolutely. And even you mentioned testosterone, right? So how many times, like, I didn't realize that. And even with some of those hormone positive patients, sometimes I actually mention and I say, go discuss a possibility of testosterone with your oncologist. And then, because that can be converted in either androgen or estrogen. So again, you don't know where you are until your medical oncologist will be able to run that option, right? So at least you have a little bit of that. I have had patients who are like, perimenopause and they already have hormone replacement for a while, and then they get diagnosed with cancer and anything drops right away. So, and then they get put into neoadjuvant chemo.
Right. Yeah. And there is some evidence that people who are on hormone therapy who are having this benefit of reduced joint pain, for example, then have rebound joint pain when that is withdrawn. So certainly like that group of people could have a lot of like newfound joint pain in multiple joints, during that transition. And it may be extra hard if they're then transitioning to not only not being on hormone therapy, but potentially being on a blocker, so that could be a really hard transition for people. And, I will see sometimes people who are, my apologies, there's some background noise here. I don't know if you can hear. Like I'll see patients who have, maybe seen someone been told, well, I don't know what's wrong with your knee, the MRI, and they'll have x-rays that look pretty normal and they'll have an MRI that looks really normal. And someone may even be considering offering them a knee arthroscopy, for example, like, oh, I don't know, maybe it's this plica that's making your knee hurt, or we can take a look and do a scope. And in reality, the reason that they don't have much pain, but their MRI is normal is really more of this sort of systemic inflammatory effect on their joints. And they don't need a knee arthroscopy. And it's important to recognize that too.
Yeah, that's a very good point, because many times is that, right? It's like, okay, we do a knee because this is kind of what we know what is going on here. And then everything is normal with that. So what else systemically is going on that we got to fix first to kind of get that going? What role does an orthopedic surgeon plays as a part of a multidisciplinary survivorship care team? I
think the most important thing we can do is keep people moving. And so like I've had patients who have been on, aromatase inhibitors for many years who, I don't like to overuse steroid injections, but I've had a patient or two where, they're just like so limited by some of the effects of these medications. And I don't mind giving them an injection sparingly or once a year so they can continue to walk and be active and maintain their cardiovascular load, things like that. I mean, paying attention to risk of frozen shoulder, paying attention to bone pain if someone is maybe getting like a stress reaction or a stress fracture as they're trying to be active. I think like we just need to be aware that there's going to be like increased risk of joint pain, frozen shoulder, bone issues, bone stress reactions, for example. Making sure that I'm not spying on anyone's medical care, but making sure that they're aware of like, oh, did you have a DEXA scan? And like why they need to stick with these treatment plans, like why it's important for them to follow their bone density just, helping them understand how that all works together. But for me, a lot of times, like, I think my main goal is helping them to keep going during this process, because it may be 5 to 10 years that they're on these medications.
Yeah, that's true. We do something, and I'm not too sure if you guys use that in your clinic, but we do a body composition where we use in body, where it's kind of we're able to actually look at how much muscle mass they have versus how much fat, right? So we know breast cancer is associated with high BMI, but we like to be able to know, okay, what is that BMI coming from really? Because you can have somebody who has a really great muscle mass and their BMI can be higher, and that's not because they're having body fat, is just because the skeletal
Yeah. People can have, you can have a lot of muscle mass and have an increased BMI, or you can have a low BMI and not have a lot of muscle mass and have like a metabolic syndrome. And I do think there's also like increasingly interest in using GLP-1 receptor agonists for controlling some of the metabolic syndrome, reducing systemic inflammation. I do think, we do see all the time that there's reduction in joint pain and inflammation. With these medications, it's not one of the primary indications for it, but there are some effects of these medications on joint health. And I think that may be something that people can consider with their care team. I think there's evolving information about this. It doesn't seem to be something that increases cancer for sure. And I think this is being studied, but I do see many breast cancer patients who are actively being treated for that, but are having experiencing the benefits of these medications as well, in terms of, improving their body composition, but they still need to do strength training and maintain their muscle mass, at the same time. But I do think this can help them with some joint pain as well.
Absolutely. It's funny, we were just at breast tumor board this morning where it's saying, when our breast surgeon was saying, when are we going to just start as a practice offering this without having to have so much trouble for these medications to get paid? And if you don't have certain diagnosed, no, you don't get covered and it's super expensive. So I think that, like the medical oncologist was like, yeah, we're working on it. So we really try to work on it because we have seen a great benefit out of it. Like, again, they reduce the lymphedema rates, because we know that when patient has a BMI higher than 29, that put them 3 times in the risk of lymphedema. And as well, if their BMI is that high and they are like PR positive and they're postmenopausal, they put them in another high risk for breast cancer recurrence. So we know that that's super important. And that's kind of what we use a lot to educate patients about their skeletal muscle mass and being on NIs. So we were like, look, we gotta get that skeletal muscle mass to be higher, because that's what's gonna help for your bone health. That's what's gonna prevent hopefully some of these things. So to try to really emphasize a lot of that strength training and try to develop some muscle, not just with that, but some, improve nutrition, protein intake, those kind of things to try to help with that.
Yeah, and even more important if someone is on a GLP-1 receptor agonist, because there can be like loss of muscle mass with the weight loss. So even more important to help them maintain that. And it's a win-win for bone density, metabolic health, things like that. But you're right, like, yeah, obesity is associated with greater risk of cancer as well. So that's a good thing to be combating.
Absolutely. And then since I mentioned a little bit of nutrition, tell us a little bit about your book.
Yeah, I co-authored our book, The Complete Bone and Joint Health Plan, which was released about a year ago with my longtime friend, who's a registered dietitian, Sydney Nitskorsky. And it includes information about obviously bone health and joint health. So, there are many necessary components in our diet for bone health beyond just calcium and vitamin D, magnesium, vitamin K, vitamin C, things like that. Dietary fiber, very important for bone health and an anti-inflammatory diet. And then there are, certain components of diet which can be helpful for reducing inflammation, which is important for both bone and joint health. And so we sort of pull all that together, as well as just sort of general advice and some specific advice on exercise for bone health, which of course includes a combination of resistance exercise and impact. And then also it's good to include some agility and balance work, so you hopefully don't fall and break anything. And then we just answer a lot of the common questions about bone and joint health, because people just really don't understand arthritis and osteoporosis very well. So yeah, so it's kind of a layperson guide really to bone and joint health. And there is quite a lot of information in there as this relates to menopause, of course, because that does ultimately affect bone and joint health quite a lot, because women are, of course, more prone to osteoporosis and arthritis, some of that related to the menopause transition. And then yeah, I think, breast cancer has all these unique factors, which do in many ways mimic some of the menopause transitions, but, an extra layer of challenge because many people are not able to use hormone therapy. So that makes diet and nutrition all the more, diet, nutrition, exercise all the more important. And then I think, there is this greater likelihood of needing some of the medications to protect bone health, especially again in the setting of use of aromatase inhibitors, like the bisphosphonates, like we talked about.
Okay, great. And then people can find the book on Amazon, any other.
Yeah, Amazon or Barnes and Nobles. Yeah,
Awesome.
yeah,
I'll put it on the show notes so people can reach.
yeah. And then,
Uh,
as you know, I try to share mostly educational things for people about, evidence-based things about bone and joint health on Instagram.
yes, yeah, and that's kind of, I think I came across you. I think you were interviewed by another of my podcast.
Another PT, yeah.
That was great. What questions should women ask their healthcare provider, like a primary care physician, regarding bone and joint health during menopause?
Well, I think one thing people should really advocate for, which is typically not done until the age of 65, is having a DEXA scan to measure your bone mineral density at the menopause transition rather than waiting until age 65, because I think it is a helpful piece of information for decision making. And kind of knowing where you're at that time point when, women do have an accelerated decline in their bone density starting really 2 years prior to menopause. And so it just doesn't make sense to me to check this for the first time at age 65, where it's going to be more of like to treat or not to treat osteoporosis rather than to prevent. And one of the decision points that people are often making at age 51, 52 is whether or not to use menopausal hormone therapy. And I do think I think it's hard to make a truly informed decision and really participate in shared decision making about whether or not you want to use that, not really knowing where you're starting or where you're at age 51 or 52, where maybe for the 2 preceding years you were already losing 2.5% of your bone density per year. And so I think that is something people should advocate for. It's hard sometimes because insurance companies often don't cover this until age 65, but it's pretty easy to come up with a list of risk factors, like being a menopausal woman is a risk factor, family history, history of medications that make you more likely to have low bone density, like, like even antacids for, reflux, being on steroids, having an autoimmune disease, inflammatory conditions, having a thyroid condition. I mean, there are all kinds of reasons why ways you could justify something. But I hope that eventually that standard moves towards the menopause transition rather than age 65. So that's something I think people should really advocate for with their doctors.
That's great. Wow, you mentioned something about anti-reflux medication. I didn't realize there was a correlation with osteoporosis.
Well, it's more just like people who are on antacids they can have diminished calcium absorption. So that can be there are various medications that can contribute to poor bone health over time, if they're used, chronically.
Okay.
Like systemic steroids are one, but that's usually not avoidable for people. Like, it might be someone who has an autoimmune condition and they're on these medications frequently or long term, for example, or again, an aromatase inhibitor is not necessarily like avoidable, but has, downsides. Various seizure medications, for example, can be a risk factor for low bone density. So there are a lot of classes of medication that can be an issue.
Okay, got you. And what emergent research excites you the most about menopause and musculoskeletal health?
Well, some of the research I'm working on, on how menopausal hormone therapy may benefit women and help reduce risk of frozen shoulder. And then I think we have so much good information about the bone protective effects, the fracture reducing effects, the risk reduction for osteoporosis. But where we need to keep doing more work, and some of the work I'm doing is looking at how joint health is affected over time. And, like I said, we do know that women over 50 are much more at risk for arthritis, especially in the knees, for example, as compared to men. But what we need to do a better job of studying is how the cartilage is protected or not by hormone therapy. And that's some of the work I'm trying to get off the ground and continue. We need some more grant money to kind of continue our work, which kind of is a jumping off from our work on post-traumatic arthritis after ACL injury. But we're trying to look at women in the menopause transition with and without hormone therapy to use the same methods we use on studying cartilage health for people who've torn their ACLs, except for the injury isn't an ACL tear, it's menopause. So in terms of the losing that protective effect on the joint. So so we're taking some of our previous research on ACL torn knees and applying it to the menopause transition to study cartilage health.
Excited to hear about it in the future. Cannot wait.
Yeah, I just need a few $1 million to finish the study.
We want to make sure that
we have
Come on.
Yeah, we've got several grant applications into the NIH, multiple rounds, but we just need some more funding. So
Yeah.
yeah.
What message would you like listeners to remember about staying strong, active, and healthy throughout menopause and beyond?
So very important to continue to, or if you aren't already doing it, include strength training in your weekly routine, 2 or 3 days a week. Regular walking is a great tool. You can do this briskly for cardiovascular exercise, but it also helps to like maintain your gait speed, reduce fall risk, and over time, reduce hip fracture risk. And then, trying to get in some more intense cardiovascular exercise 1 or 2 days a week where you're doing like sprint intervals to help you maintain your cardiovascular health as well. So, I think those are kind of mainstays of the kind of exercise program people should participate in. Also some jumping or impact, as that's good for helping to maintain hip bone density. Now, not everyone can do all these things. The other thing I like to tell people is like, give yourself some grace, pay attention to what you as an individual can do. Just because you hear, people saying you have to lift heavy, you need to do jumping, all this stuff, that might not be for you, and that's okay. I think it's really important for people to find something they can do without injuring themselves, because if you get injured, you're not going to be doing anything. And so, while we think it's good and helpful for maintaining bone density to do jumping and impact and to do resistance training where the load is being applied to your whole axial skeleton. If you cannot lift really heavy weights, that's okay. Like there is still benefit to like a moderate intensity, kind of a higher repetition, lower weight approach. And so I think what I want people to take away from this is, figure out what you can do sustainably without taking yourself out of that routine. And, in whatever way you can, you might need to work with a physical therapist to find a way to do this. Get your 2 or 3 days in of resistance training, get your cardiovascular exercise in. 150 minutes a week, moderate intensity would be ideal for various reasons, heart health, brain health, all those things. But you navigate, you thread the needles you need to thread if you have arthritis or aromatase inhibitor, musculoskeletal syndrome, things like this, and just like find what works for you. It doesn't have to be the highest impact and the heaviest load, and it's still better to be active and be doing those things that contribute to, you're reducing your risk of falls, maintaining your bone density, maintaining your cardiovascular health. Don't feel defeated if you can't do the most intense version of everything.
That's a great point. And sometimes what I find myself as well, some patients are kind of afraid to progress, right?
You don't have to lift at the highest intensity. That has been shown to have a larger effect on bone density, but the classic, the lift more trial, the lifting at 85% maximum, of a single rep max, where you're fatiguing by the fourth or fifth repetition, that really heavy lifting, that really isn't feasible for everyone, and that's okay. If you can do that, that's great to progress to that and include lifting at that intensity. But you also, as you mentioned, don't want to be just kind of aimlessly curling 2 pounds forever if that's super easy for you. You do want to kind of progress, but find what you can progress to without injuring yourself, which is again where a physical therapist can be so helpful.
Absolutely, yeah. And then we always kind of there to coach them through that progression of exercise. So that has been so amazing. Where can people find you, Dr. Whitson?
Well, I work at Duke in North Carolina, but most people aren't in this direct area. And then, so I'm, on that website. I'm on Instagram. It's just Jocelyn_Wittstein_MD. You mentioned where our book is. And that's where you can find me.
And I'll put that in the show notes. So again, thank you so much for being part of this show. I really learned a lot and I really enjoyed this conversation with you.
Thank you for having me and putting up with me being in an OR lounge after cases.
No, thank you.
This bad lighting.
No,
Thanks.
absolutely. Thank you so much. And you have a great rest of your evening.